MET as a primary driver, I think absolutely when you hone down on these specific genetic biomarkers. MET as a secondary driver, I think has taken a few body blows. We have to understand that MET was described as a second driver in EGFR mutant cancer that developed acquired resistance to an EGFR tyrosine kinase inhibitor. And yet, the studies that have been explored have been much looser than that. So we've seen studies with alatinib and crizotinib combined together, but in an unselected population that was really fairly uninformative. At last year's ASCO, we saw a very interesting presentation just done in EGFR mutants. And then if you looked at the ones who had acquired resistance, that if you had high-level MET amplification or even high-level MET protein expression by immunohistochemistry, you would get great responses. So you're selecting out where MET becomes in the relevant context. The reason MET even has a bad name is probably because of some studies that were probably not optimally designed in retrospect, and that includes the MET-MAP studies. So these were antibodies against MET combined with alatinib, but they weren't done in an EGFR mutant population. They weren't even done in an acquired resistance population. And there was an initial kind of false dawn because they had a phase 2 study that looked promising, which is actually very flawed and probably explanation for the positive result in the phase 2 that was then negative in the phase 3 was that it was massively imbalanced in terms of EGFR mutations between the arms. And so it was very easy to predict that their phase 3 study was going to be negative, which it was.